Back to small cell, because this is the case. Lonnie, is there any different approach? I imagine there's not, but is your approach different at all to a biopsy for small cell versus non-small? Does it require less tissue because you're not getting molecular testing? I mean, do you approach this any differently if you were the one getting the tissue on this patient and you thought maybe this was a small cell patient, or your first pass showed it looked like small cell?
Yeah, no, I think the general approach is the same. I think the additive benefit of on-site cytologists is really important because the on-site H&E can be confusing, especially in small cell. So having that feedback to really definitively figure out what you're dealing with and then have a stop point is important.
Is your on-site, if they're like, this is small cell, are you like, okay, I don't need that much tissue here? I mean, does it guide you in some ways in terms of how aggressive you're going to be with the tissue procurement?
Yeah, completely. Because again, as discussed earlier, I think one of the major benefits is using it as a complication reduction tool, so that I don't need to move on and do additional biopsies or higher risk biopsies. So having that nice safety stop point is a nice factor.
Sam, just the role of the pathologist here for small cell, IHC staining, do we do any other testing, how you approach this for a small cell in the context of what you usually do for non-small cell?
So it's certainly different. Once it's small cell, which means it's got neuroendocrine features, it's going to be positive for your neuroendocrine immunohistochemical markers. That it certainly does not have the biomarker workup like we'd have in a non-small cell. We look for any features of non-small cell. So again, neuroendocrine can be a component of a mixed tumor. If you see any of those features, you are going to want to go ahead and do the complete adeno or non-small cell biomarker workup. But in a patient where it's a pure small cell, no evidence of anything else, I think it's handed off to the rest of the team.
Do you ever get samples that are mixed non-small, small cell? I mean, do you get a mixture of them, or you can't determine whether it's non-small cell or small cell? It's just poorly differentiated. We asked this before between an adeno and a squame, but do you ever get that? That's just tough to tell.
So I should point out, actually, the language has evolved here. We now talk about these as neuroendocrine tumors, and you certainly have large neuroendocrine tumors and the small neuroendocrine tumors, which is what we talk about when we talk about small cell. So I think as soon as you have those neuroendocrine features, which you identify by your standard immunohistochemical markers, you know you're in that category. If it's a pure small classic small cell neuroendocrine, we sort of know what to do with those. If it's anything outside of those, I guess if it's a pure larger large cell neuroendocrine tumor, we would probably still not do the biomarkers. But if it has any features or the neuroendocrine staining is discontinuous, I think my perspective is having that information helps to manage the patient, especially in the absence of clear data that says that they're not going to benefit, and kind of make it part of the multidisciplinary discussion. If we don't have the data, we don't know what we're looking at.
And one of my favorite questions to ask pathologists when they get a small cell, or maybe even a large neuroendocrine tumor, or neuroendocrine tumor in general, and the pathologists may be rolling their eyes when I call them and ask this, but do you get a Ki-67 on these patients? Does that help you determine the proliferation rate of the small cell? For medical oncologists, we like getting a Ki-67. Is that something routinely done in small cell?
We can. These are highly proliferative tumors, so the Ki-67 is going to be high. But if it's not, it's really the neuroendocrine features that are going to make the difference. I guess we'll do it for you if you really want it. It's an easy test to do.
I think it's incorrectly stuck in my brain that makes a difference in some way or shape. I mean, sometimes we're trying to understand the tumor biology, and small cell is so tough because we're grasping at straws in terms of how it behaves sometimes. We know it behaves aggressively, but some of these neuroendocrine tumors, trying to determine what chemotherapy to give them, sometimes if they have a high Ki-67, I default more to my small cell regimens, and if their Ki-67 is low and they're in advanced stage, I default more to my non-small cell regimens based on very little data.
Yeah.
But
I think you make an excellent point that we have the standard guidelines, but each patient, we live in the era of personalized medicine. Each patient is each patient, and there may be biologic features. For purposes of trials, we have to bucket them, but there may be individual features. A good pathologist will see that they'll call and say, hey, I'm going to call it this, but it's got these really unusual features, and this is how you should be thinking about the biology, or it's not quite typical. So I do think if you think a Ki-67 helps you, by all means, I'm happy to do it and get it for you.